Hello, everyone. We're now moving on after what Caroline said about having a high suspicion for aspergillosis, think aspergillus, so that the diagnosis is not missed, and also what Lily said about the challenges for diagnosing aspergillosis. Hopefully, we have reached at the correct diagnosis, and we would like to offer treatment for aspergillosis. I would like to focus a bit more on chronic pulmonary aspergillosis, because that's the condition that we mainly funded to treat here at the National Aspergillosis Center. However, I will also mention what is the standard treatment for ABPA and also for invasive aspergillosis. So, of course, when we think about treatment for CPA, the most important is to make the patient feel better. So how do we improve the quality of life? By minimizing symptoms, and it will be different for each patient. For some patients, what is more severe is, for example, weight loss, or some will feel very severe fatigue, or the amount of sputum, for example. So we have to individualize the approach and try to see what benefit we can offer. What is also not very easy to understand sometimes is because CPA always occurs in people who also have some underlying lung disease. It is possible that some of the symptoms are those of the underlying lung disease, like emphysema, for example. A particularly important symptom in CPA is hemoptysis, or coughing up blood, which of course can be distressing for some patients. And this is something that we always like to try to address specifically, if we can, with interventions if needed. Thirdly, CPA is a slow condition, of course, gradually resulting in scarring of the lung and loss of lung function. So ideally, our treatment strategy should also, or our treatment aim should be also to try to stop the progression of the scarring of the lung. And finally, as this is a condition that requires treatment with antifungal drugs for usually prolonged periods, what always happens with infections is that germs are quite smart, and they try to develop resistance to the antibiotics that we throw at them. And this is also the case with aspergillosis. And also using antifungals for a very long time can lead to side effects of antifungals. And Fiona, our pharmacist, will cover antifungals in more detail very shortly. So what you need to know for now is that there is only one class of oral antifungals which have activity in chronic aspergillosis. And of course, we use 4 different antifungal drugs, but they belong to the same class, which means that aspergillus can develop resistance to all of them at once. However, if a patient is treated with one antifungal and develops side effects, it's possible that they can be treated with another drug and tolerate that much better. In CPA, we tend to treat for prolonged periods. The usual recommended duration is 6 months. So where does this come from? This is actually, well, it's expert opinion. This is what we go by. This is guideline, which is a joint guideline formed by European infectious disease and respiratory specialists from 2016. And as you see, the recommendation that has been put there is at least 6 months of antifungals, but also some patients may benefit from even longer courses of therapy. Sometimes we see that the response to treatment is slower, so we reach the 6-month point, and there is some improvement in the symptoms, but we feel that we may need to continue for longer. So some patients stay on antifungals longer than 6 months. There are some patients who could be at high risk of relapse, which means that after stopping the antifungals, the symptoms might come back or might get worse. And this might be approximately maybe 20% of cases. We will see that symptoms might come back. So some patients may have to stay on treatment for prolonged periods, many years, or even lifelong. And this is possible as long as the medications are tolerated. Finally, as I said, as there is only one class of oral antifungals, sometimes we often have to resort to intravenous treatments. Of course, for prolonged courses, they're not very practical to have to administer intravenous treatments for a very long time. But our intravenous antibiotics team, the OPAT team, is very helpful with that and can arrange even IV antibiotics at home. And Liz will talk about that also shortly. So please don't worry too much about the slide. It's quite complicated. It just shows the number of studies that have been published in the past and the year of publication about various antifungals. So on the left-hand side, you see in blue the different antifungal agents, and on the right, what's quite interesting to see is the response rates in percentages. So as you see, in most of the antifungals, the response rate is about 60%. So the majority of patients will respond to treatment. Of course, there is a subset of patients who unfortunately would not respond right away, but might respond later, or we have to change the treatment. But how do we as doctors assess response of a patient to treatment? First of all, as I said before, is the clinical improvement, so the symptoms improvement, which is the most important for the patient. Of course, the clinical response is something, but it is a subjective response to treatment, which always ideally we would like to have also an objective response to treatment, which is radiological. So we use chest CT scan to do that. And finally, we can use blood tests, mainly serology. As Lily mentioned before, there is a test which is we can test for Aspergillus antibodies in the blood. Now, this sometimes does not always give the full answer, because sometimes if somebody is exposed to Aspergillus a lot, the antibodies can go up. It does not mean that this is definitely deterioration of chronic aspergillosis, but sometimes with good response to antifungals, we can see the Aspergillus antibodies also going down. That's also very good to see. So what symptoms should we be looking at? Which symptoms are the ones that improve? Again, it has to be individualized. For some patients, the most important thing would be weight loss. For some patients, it may be energy levels. So this is from a study from the NAC a few years ago, when we looked at the response of treatment with posaconazole in CPA. And what was used is that for improvement, for example, they considered a weight gain of more than 3 kilos, increased energy levels, improvement in breathlessness, improved exercise tolerance. On the other hand, the opposite symptoms would mean a clinical deterioration. So also hemoptysis, the blood in the sputum, would be a sign of deterioration, or poor appetite, or a high sputum load. So of course, it has to be individualized per patient, as I said. Of course, in some cases, we could see stability, neither improvement nor deterioration. That sometimes is an encouraging sign, because there have been deterioration before starting treatment, and we can hope for stability while on treatment. So it's possible that sometimes the improvement takes some time to start happening, and sometimes stability by itself is not necessarily a bad thing. In this study, we looked at also different radiological aspects. I will show you a couple of scans in a minute, and I will try to explain what we use as markers of improvement. So we can, of course, record the patient's symptoms as they report them, but of course, we have some tools that can help us to do that. And if you have been seen at the National Aspergillosis Center with CPA, you will probably know this questionnaire. This is a validated questionnaire that is used in respiratory research in general, and also we use it in the NAC, and it has been shown to correlate with improvement or failure of improvement of treatment. So this is it takes quite a bit of time to fill it out. I think there are about 50 points in that questionnaire, but this is some examples of questions that will be asked. So they are scored according to how severe are the symptoms, and then we can compare before and after treatment, and we can be more informed about having a number there in addition to the patient's symptoms, that whether the symptoms are improving or deteriorating, and whether antifungals have helped. But of course, others have used other tools. For example, this study of voriconazole used what's called a visual analog scale, where they would ask, how bad is your cough from 0 to 10? How bad is your breathlessness from 0 to 10? And so on. And as you see in this study, there was improvement of the cough, of the breathlessness and sputum production on the antifungal drug. But of course, you might know that we like to also rely on objective findings, and the best tool we have nowadays is a chest CT scan. Unfortunately, the chest X-ray is not that detailed to help us so much to decide whether treatment in CPA is helping. And what has been shown and what we know is that some of the features on the CT scan also have a good correlation with the clinical improvement. So if the patient is feeling better, there are some features on the CT scan that usually we see. So for example, you will see on the left-hand side, there's a chest cavity. What we see, what is usually the appearance of chronic pulmonary aspergillosis. And this cavity is thick-walled, which usually means that there is a lot of inflammation in the wall of the cavity. And on the right-hand side, this is the same patient who had a scan after 6 months of antifungals, and the cavity wall thickness is much less. So for us, that would be an encouraging sign that the inflammation is subsiding. So the response is good here. And also, in some cases of CPA, there is what's called a fungus ball. It is not in every case, but in a lot of cases, you can see fungus ball, which is basically material of some fungus inside the cavity that is present there, along with some inflammatory cells of the body. And you will see in panel A is before the scan, and you will see that this is the fungus ball that was present. And in the repeat scan after 6 months, this fungus ball is actually probably appearing smaller here. So that is another what we consider to be an encouraging sign that the treatment is working. So as you see, even after 6 months of treatment, there is an improvement, but it doesn't mean that you would necessarily stop the treatment there. You might have to continue being encouraged that there is a good response. You would continue beyond 6 months, up to a year or even longer, and repeat the scan again after 6 months to see if there is ongoing improvement. Now, I mentioned before a very important symptom in CPA and all aspergillosis syndromes is hemoptysis, or coughing up blood. And this, of course, can be distressing for patients and can be sometimes life-threatening if there is large amount of blood, of course. So there is a intervention that we can be offered also here, and this is performed by interventional radiologists who will try to specifically block any bleeding arteries in the lung. So what they do is that they would place a catheter through the groin into one of the arteries, and this then goes up to the lung. This is a large artery called the aorta, and some smaller vessels start from the aorta and go to the lungs. And in aspergillosis, because of the continuous inflammation in the lungs, those arteries in the lungs may grow more. They become, as you see, more contorted, and they will grow more. So then they become more friable and they can bleed easily. So what our radiologist can do is they can go into those arteries and try to release some small particles, and these are then go and block the bleeding vessels. So of course, this can be used as a bridge to surgery if surgery is being planned, or of course it can be used on its own, but of course there could be, the bleeding can come back in the future. It is not without complications, so we try to reserve that for people who have a really large volume of blood, not for everybody with small volume hemoptysis, because it can, of course, because you cannulate the arteries here, there could be complications like bleeding as well, or sometimes even they can block an artery by accident, so it can have side effects. There is a tablet called tranexamic acid that is also quite effective at reducing bleeding, but of course this cannot be very long term. Some patients can stay on it for a very long time, but it's always good to have a approach like embolization if possible. The more definitive treatment for CPA, especially when antifungals do not help, is surgery when it is possible. This can offer the prospect of cure. So we have quite large experience here at the NAC with our thoracic surgery colleagues, and the experience has been published over the years in a couple of publications that we have shared. So what we see is that, of course, it is feasible to cure CPA that way. There could be complications after the operation, and that happens probably because patients who have surgery for aspergillosis may have also other underlying diseases like COPD, Or, of course, the amount of scarring in the lung because of the aspergillosis may mean that there could be complications. But, of course, the majority of patients are there cured from the aspergillosis. A number of patients, maybe 20–30%, may eventually have a relapse, which means that what usually happens is in the first 3 years, but can happen later. You can have a new site of aspergillosis developing where the operation has happened or in the other lung. And that's mainly because these patients will have predisposing conditions to lead to aspergillosis again. So then relapse can happen. Very briefly, I will mention other forms of aspergillosis that we might see that could be similar to CPA or would be within the CPA spectrum. In some cases, there is a term lung nodule, which of course raises suspicion for cancer. And what can happen is these patients may have a biopsy or the nodule can be removed. And what we see there is you can see fungal organisms instead of cancer, which of course is reassuring for the patient, but and you may have to then follow those as well in the future. So it could be that you don't need to treat that if the nodule remains stable. So basically you have to follow this nodule as you would with any nodule in the future. So repeat x-rays or repeat scans. And if that nodule enlarges, you may again have to think about the possibility of cancer, or again, you may want to try antifungals if you're convinced that there is no tumor. There's also another entity called simple aspergilloma, which means that there is this fungus ball inside the cavity, but this is usually well circumscribed, does not cause much in the way of symptoms. So in those cases, you don't necessarily need to give antifungals. You can just follow it, for example, with yearly x-rays, and it's perfectly reasonable that this just needs follow-up with x-rays and no treatment. Of course, it can lead to bleeding sometimes, and then you might have to involve the surgeons. Now, moving on to allergic aspergillosis, this is a different entity. As Caroline said, this can complicate mainly asthma or another less common condition called cystic fibrosis. And ABPA treatment is similar to that of asthma in that in exacerbations, you have to give steroids initially. So the ABPA exacerbations are usually more prolonged than those of asthma, and they may be accompanied by more profound symptoms like fatigue and feeling unwell for prolonged periods, and a lot of sputum production, which is usually very sticky or sometimes with blood as well. And steroids is what helps actually in ABPA acutely. And usually the doses and the duration of treatment is longer compared to what is used for simple asthma attacks. So sometimes for asthma, you might give steroids just for 1 week. For ABPA, we tend to give for several weeks, sometimes more longer than 4–6 weeks. And we then try to reduce the steroids gradually rather than stop them, because it could be that the ABPA will flare again soon. So typically we start with steroids and we continue for several weeks. The antifungals have a significant role here because they can act as steroid sparing drugs. So if you stop the steroids, then the ABPA will flare up again. And it's not ideal if somebody stays on steroids all the time. So antifungals like itraconazole can be used so that the steroids can be stopped. So you can start both steroids and antifungals at the same time, then stop the steroids, and then remain on itraconazole for a prolonged period of time, could be several months, while the symptoms improve and while also the allergy markers that we use also improve. And then you can try to stop antifungals and see whether the ABPA relapses. It's possible that it might not relapse. But again, unfortunately, it's possible that some patients will have relapses of ABPA, and they might have to stay on antifungals for prolonged periods. Remember, as I said, ABPA happens in people with asthma. What's important is that to try to also optimize the asthma management, for example, with inhalers or other medications. And most patients with ABPA also have a condition called bronchiectasis, which means dilated airways, which leads to increased sputum production and a lot of infections. So again, that has to be managed at the same time. Biologics are a relatively new class of drugs that are used in asthma, and this is also shown to be helpful for ABPA symptoms. So this is also something that needs to be explored in addition to antifungals and steroids. Invasive aspergillosis is the most severe form of aspergillosis, and because it mainly affects people with severely weakened immune systems, like transplant patients, patients on prolonged steroids for a very long time, or those who have very low white blood cell counts because of chemotherapy or blood conditions. And because of that, the mortality is very high in invasive aspergillosis, because the immune system cannot really fight the disease, and especially if it's not diagnosed very early. So the tools that Lily mentioned are very important in invasive aspergillosis, especially if the doctor has a high suspicion for it. So if it is diagnosed early and treated early, then the outcome is a lot better. And the principles of antifungals are generally the same, although we do not use itraconazole in invasive aspergillosis. Just hasn't been shown to improve outcomes as much as other antifungals like voriconazole or isavuconazole or amphotericin B. The treatment duration is generally shorter compared to CPA, because the patient might improve, and then especially if the immune system picks up, and then they are able to control the infection. But of course, it's a very important condition to diagnose early, and outcomes can be better if it's diagnosed early. So these are the three main syndromes of aspergillosis that we treat. As you see, they are relatively different in terms of treatment, although the principles are the same, and you will hear more about the antifungal agents shortly. Thank you.